Today we are going to discuss a topic that goes way beyond numbers and calories on the scale. I'd like to introduce Professor Richard Holt. Richard is going to tell us what he does, but before that, let me tell you today the topic is very interesting. It is about weight loss medication. So Richard, over to you. What do you do? Where do you work? Tell us a little bit about yourself.
Shania, hi, thank you very much for inviting me to take part today. So my name is Richard Holt. I'm a Professor of Diabetes and Endocrinology at the University of Southampton. So I have a mixed role in my work. So half of the time I work as an NHS diabetes consultant, looking after in particular young adults with diabetes, but also people going through pregnancy and also those with cystic fibrosis diabetes. But on the side of my academics, as well as teaching and administration, I have quite a large research portfolio, and particularly looking at the interrelationship between physical illness and mental illness. And that started some 20 odd years ago now, when I just became very interested in why people with schizophrenia and bipolar illness have more diabetes than the rest of the population.
Yes, Richard, and we've worked together on the stepwise trial, and indeed you were one of the pioneers in working on weight loss medication for individuals who have severe mental illness. You've done a trial on Liraglutide some years ago.
Well, you're very kind to say that, Shania, but of course one of the things that has really interested me is how to stop people with severe mental illness going on to develop diabetes, and one of the keys of doing that is to try to control body weight. And you mentioned around the stepwise study, which was a lifestyle intervention, so providing people with severe mental illness with the skills and knowledge to change their lifestyle in order to either lose weight or not gain any more weight. Sadly, that trial wasn't successful, and if we look at a lot of the trials around lifestyle management in people with severe mental illness, we find that it's not as successful as we would like. In fairness, actually, in the general population, lifestyle change is not that effective, because if it was, we wouldn't have the problem of obesity that we currently face. And we can see from the trials that even in the general population, only about 2 in 10 people actually respond to lifestyle changes. And it would seem that among people with severe mental illness, it's certainly no better than that, and it could be even worse, which is why I then went on to start to look at whether drug therapies may be appropriate. And the clinical trial that you described was using Liraglutide, one of these new weight loss drugs, to try to treat obesity among people with severe mental illness. And although it was a small trial, it was a successful intervention for those people who took the drug in the trial.
We had some very good feedback from it, and I'll put the reference to the published paper in the description when the video is published, Richard. So obviously in my mental health clinical practice, I see a number of individuals who ask me about weight loss medications, and they have grown popularity in recent times. Obviously, I'm not an expert, but I'd love to hear about how they work.
So it's very interesting. If we actually look at the history of weight reducing drugs, it's got a very checkered history, but for the first time, we now appear to have drugs that are not only effective, but also safe. And these drugs really came out of treatments for diabetes. And what they do is they mimic the action of one of the normal gut hormones that is important in terms of glucose metabolism. But one of the other actions is that they feed back to the brain and actually tell you that it's time to stop eating. So what was found during the clinical trials is that people with diabetes taking these drugs to improve their glucose levels also had significant amounts of weight loss. And so the drugs have now been repurposed, used at a slightly different dose, to treat people with obesity. And there are now 3 of these drugs that have got specific licenses to be used to treat obesity as well as to treat diabetes. And those are, as you mentioned, Liraglutide, but we now also have semaglutide, and the most recent kid on the block is tirzepatide.
Yeah, when I was planning this interview with yourself, Richard, I put out some questions on the community forum and different forums. And one of the questions that came up was that, are these medications purely physical in their action, or do they affect parts of the brain that affect mood and specifically the reward system?
Yeah, no, that's a really, really interesting question. As I mentioned already, I mean, the drugs certainly act on the part of the brain that's important in terms of regulating appetite and your basal metabolic rate, which is how quickly you burn energy. So they're certainly acting on that part of the brain, but also they appear to have much broader actions within the brain. And in fact, there are now some clinical trials to see whether these drugs might be useful to treat Alzheimer's disease.
Okay.
And there's also some preliminary evidence that's come out of the obesity trials that these drugs are actually quite good for mental health as well, so reducing depressive symptoms, which may be important. There was maybe a couple of years ago, or 18 months ago, there was a concern that there was a signal coming around suicide with these drugs. But I think that that's now been put to bed. I don't think that the studies that have been done subsequently have actually confirmed that observation, and so I don't think that suicide is a worry with the drugs. But of course, it was something that had to be investigated, and thankfully not shown to have that effect. So yes, I mean, these drugs have quite wide effects on the brain. Whether some of the improvements in mood you get is a direct effect of the drug, or just the fact that people feel better because they've lost weight. And we know that having overweight or having obesity is bad for your mental health. It is bad for your self-esteem. You are likely to suffer from stigma and discrimination from other people. So we know that obesity per se has quite a major effect on your mental health. And so when you start to look at the trials and you do see improvements in mental well-being alongside the drugs, it's difficult to know whether that's a direct effect of the drug or whether this is an indirect effect because you've helped lose weight. I mean, I guess that's a slightly academic argument, because the important thing is that for people taking it, they do feel better.
Exactly, yes. And I suppose all this is new on the block, so there will be more research evidence coming out on which areas of the brain specifically, if it does help mental well-being.
Yeah.
I guess all that is yet to be revealed.
Yes, absolutely. I mean, as I say, the drugs started off as diabetes drugs, and now they've become an obesity treatment. They're also being used for certain types of liver disease. They're also now being trials for Alzheimer's to see whether they can improve Alzheimer's. So who knows where this is going? It's a very exciting time. And, you mentioned that I did the trial with Liraglutide. Well, with the newer agents that have come on, we know that they are firstly more effective, but they also have to be taken less frequently. So instead of having to do a daily injection with Liraglutide, with both the semaglutide and the tirzepatide, you're having to give a weekly injection, which of course is a benefit to, once a week injection rather than once a day injection. But, this isn't the end of the story. This is really just the beginning of the story, and I'm sure that we're going to be seeing many more drugs that are coming out that are mimicking some of the body's natural hormones that are there to help control body weight.
Yes, I completely agree with you, Richard. And that's where research is so important.
Oh, absolutely.
So then what about side effects? Because there's a lot of talk about side effects, eyesight deaths, those kind of things. Again, me not being an expert, I guess this is something that people have also asked me to ask in this interview.
Sure. So by far the commonest side effect that you get with these drugs is gastrointestinal. So feeling nauseous, feeling bloated, having diarrhea. So by far those are the commonest side effects. And actually, in a sense, you can understand why that is the case, because if you overeat, your body's response is to tell you to stop eating. So I'm sure that everybody at some point will have had a feast at some point where they've eaten too much. So you know how when you've had your Christmas dinner or a birthday party, at the end of the evening you can feel a little bit full, and if you eat a little bit more, you might feel a bit sick as well as feeling a bit bloated. And of course, if you continue to eat, eventually you'll make yourself sick like the Romans did. And part of the reason for those feelings of bloatedness and nausea and vomiting, if you keep going, is because of the the production of these hormones from the brain, from the gut, telling the brain, look, it really is time for you to stop eating. And so, of course, when you're giving these drugs as a therapy, you are already rising those levels of those hormones to cause those gastrointestinal side effects.
Okay.
And one of the ways that we try to stop that from happening is partly by giving people advice about how to eat. So don't take a really big meal altogether really quickly, because you're more likely to start to get the side effects. But also, when we are introducing the drugs, we start at a low dose and then gradually build up the dose as people become used to taking the drug, and that often helps. And so what we often see within the clinical trials is that the majority of those gastrointestinal side effects occur within the 3 to 4 months of starting the treatment, and you always see a little bit of a blip of more side effects when the dose goes up, but if you can keep taking them, eventually those side effects will go. So those are by far the commonest. So the second you mentioned was around death. Now, clearly, we're not wanting to use a drug that's going to cause...
It's in the media so much, so I thought might as well.
We certainly don't want to be using a drug that's going to cause somebody to die. And actually, if you start to look at the clinical trials show that that death rates are actually reduced in people taking the drugs, which is obviously very exciting, because not only are you supporting people to lose weight and improving their glucose levels, you're also in the long term helping them to live longer and healthier lives, which is great. The second thing that you also mentioned was around eye disease. Now, that is also an interesting question, and it is something that was pulled up in the clinical trials, but it was pulled up in the clinical trials of people with diabetes. And so when we think about people with diabetes, there's a particular type of eye disease that can occur called retinopathy, and that's caused by changes in the blood flow to the small vessels at the back of the eye. And one of the things that's very clear about that is that that's very much a glucose effect rather than a weight effect. But what we also know from previous clinical trials is that where the glucose levels are reduced very quickly, that eye disease can temporarily get worse and then get better, or at least get worse before it gets better. And so the thought is that the reason why we were seeing this signal to eye disease, increased amounts of retinopathy in the trials of people with diabetes, is that these drugs are very effective at lowering blood glucose, and it was lowering glucose very quickly, and it might have been the very quick reduction in blood glucose that actually then triggered the eye disease, which is why when we start to use these drugs in people with diabetes, we need to be aware of what their eye status is, and if there's any concerns. That doesn't mean you won't necessarily use a drug, but what you might do is you might
take some caution.
You will take caution, like for example, making sure that people get their eyes looked at more frequently, or alternatively just titrating that, increasing the doses more slowly in order to try to prevent the development of the eye disease.
Okay, that's very well explained actually. Even I understand it better now. Richard, then are they safe in pregnancy?
So the answer is that we don't know, really. The current guidelines from the manufacturers is that people should stop taking the drugs 3 months before they become pregnant, because the effects in pregnancy are unknown. The animal experiments that were done while the drugs were being developed suggest that there were some abnormalities that developed in the babies. But whether those are relevant to humans, I think is not clear, because the doses that we use in those animal studies were much higher than the doses that we would use in women leading up to pregnancy. Because these drugs are very effective at lowering weight, and we know that obesity itself is one of the things that can reduce the likelihood of a woman becoming pregnant, that we know that there are actually quite a lot of women who are getting pregnant while they are taking the drugs. So that's an off license, so we don't recommend it, but sometimes these things happen.
These things do happen, yes.
You lose weight, you start having periods, you can get pregnant when you thought you never were able to before. And so some of those women have now had babies, and they have been followed up, and what the studies suggest is that there was no harm seen in those babies, which is obviously reassuring, that doesn't mean that we can move from the point of the recommendation at the moment, but of course it's giving us more information about the safety of the drugs as time goes on.
That's very interesting. So what happens when people stop taking these medications? Do they continue to sustain the benefits of the medication and continue to lose weight, or does it stop, or do they gain the weight back?
So what we can see from the clinical trials is that where people have stopped the drug, they will gradually regain the weight, and that weight gain can go on for a period of around 18 months. Generally speaking, they will end up at a slightly lower place than they started, but still a lot more than they had got to. So I think there's still a lot that we need to know about how best to use these drugs and how best to decide whether this is a drug that needs to be given for life. And at the moment, the license is just for 2 years for people who are taking it to lose weight. So we don't know that. But if we are going to be thinking about stopping the drug after 2 years, we need to then think about what strategies do we have to employ to stop or at least minimise that weight gain. And it may be that you start to put into lifestyle practice to prevent it. And you can imagine that if somebody is very significantly overweight before they start treatment, because of their weight, they might have problems with arthritis, which means that they can't exercise, and once they've lost weight, they're then more able to do it. I think also because the drugs do actually reduce appetite, you can maybe learn what sorts of foods you can eat and the amounts of food that you need to eat in order to maintain a certain amount of weight. So I think that there is potential for thinking about how to use these drugs, or where we go afterwards. But on the other hand, I think for some people, it may be that the drugs need to be used for longer than the current license. And of course, as we get more experience with the drugs, we might well see that the license changes to allow longer term treatment. In the same ways that when we start to think about cholesterol lowering therapy, if we start to think about glucose lowering therapy, if we think about blood pressure lowering therapy, we don't use it for a couple of years and then stop and then expect the blood pressure, the weight and the cholesterol to stay where it was. We expect them to go back to where they were before, and that's the reason why these drugs are used over a prolonged period of time. And I think that, again, as we get more experience with the drugs, I suspect there will be at least some people where you would expect that you continue to take the medication into the longer term.
Although for now they can be used as a platform to implement other types of strategies as well to bring about lifestyle changes.
As I say, if your weight is an impediment to you doing exercise and you lose weight, then you then are in a better position to start to exercise. Whereas, and so you might see that there is a rationale for using the drugs effectively to kickstart a lifestyle change that needs to go on for the rest of your life. But, as I say, it's a very exciting area at the moment. We may well be seeing more changes.
Yes, very exciting times then. In which case, if we have to stop it after 2 years, and if future evidence suggests that it may not be safe to carry on after 2 years, problem is we don't know what we don't know at this stage, right? One of the questions somebody asked me on the forum was, is bariatric surgery better than weight loss medications? What would be your view?
Okay, so I think when we think about bariatric surgery, at the moment it is the most effective treatment of obesity. In fairness, I think the drugs are getting better. So I mentioned Liraglutide and semaglutide, so those basically target one hormone, so GLP-1. Tirzepatide actually targets two hormones, so GLP-1 and GIP, another gut hormone.
Right.
And we also know that there are some treatments that are being developed at the moment that target 3 gut hormones, and who knows, into the future we might have more drugs that target even more. And so when we start to look at some of these drugs that are targeting the 3 hormones, you are getting very close to the effects that you'll get, the benefits that you're getting from bariatric surgery. So I think that at the moment, in terms of what's available, yes, bariatric surgery is more effective than the drugs, but I think at some point that tipping point will change, because although bariatric surgery is very beneficial, it's associated with longer life expectancy and reductions in cardiovascular disease. So it's a good treatment. It does come at a cost. So there are long-term complications that you can develop with bariatric surgery, such as certain mineral and vitamin deficiencies. And so where you have bariatric surgery, you do need to have continuous and long-term, lifelong follow-up in order to make sure that you're not developing some of those complications. Whereas at least with the drugs, if you stop the drug, the effects, as we discussed before, are reversible. So I think if you were asking me this question in another 10 years' time, I suspect I'd probably be very much saying that the drugs are at least as good as bariatric surgery. But, and I think the other thing to also to say is that just because you're using, or just because you want to have bariatric surgery, doesn't mean you can't use the drugs, or you can't use the drugs before you have bariatric surgery. So, I think that bariatric surgery is important. When we look specifically for people with severe mental illness, there aren't very many studies that have been done. Most of the studies have been done in people without severe mental illness, but the studies that have been done suggest that it's as effective in people with mental illness as it is in those without. But like all of the bariatric surgery, you have to make sure that you choose the right people to go forward for it.
So everybody is different, and everybody's situation is different, and that's how they need to seek help from their professional or experts.
Absolutely. So, I mentioned that lifestyle change isn't particularly effective, but for some people it does work. You look at Weight Watchers and they have the Slimmer of the Year. One of my very good friends from a long time has just lost 7.5 stone through lifestyle change with Weight Watchers. So it's not that lifestyle doesn't work, it just doesn't work for everybody. And so whereas about 2 in 10 people will respond to lifestyle change, it's probably about 6 in 10 that would respond to the weight loss medications, although that number is probably going to increase as we're getting more and more of these newer treatments, whereas bariatric surgery still doesn't work for everybody. It's maybe 8 or 9 in 10, you see. So it's trying to find the right treatment for the right person.
Yes. We hear a lot on social media about the Ozempic phase or shaming. Do you have any views on
Oh my goodness,
that?
You're absolutely...
Well, you're going to be on social media. So.
You're absolutely right about the influence of social media, and I think a lot of people hear about these drugs, not just through social media, but through the mainstream media. That just this last week, with the European Congress of Obesity, there's been a lot of news about these drugs. So yes, social media and also mainstream media, you're getting a lot of information. I was hearing that after Kim Kardashian endorsed one of the particular weight loss drugs, the sales in the United States went up by 8% overnight.
Wow.
So undoubtedly social media can have a major influence.
It does.
You also made the point about fat shaming. Well, to be honest, I think it never works. It's not people. If you ask most people who have obesity or have overweight, they don't want to have obesity. Clearly not all. Some people are very happy, but a lot of people are very unhappy about their body shape as a result of the obesity, and it's not as if it'll come as a surprise to them that they've got obesity. They know that they've got obesity, and so therefore they don't need to be reminded of the fact that they've got obesity. And when we start to think about obesity, a lot of the control that comes through a lot of the mechanisms that control your body weight, you've got no influence over. This whole feeling that obesity is a result of a moral lack of moral character is just untrue. So for example, if we look at families and look at genetics, we know that genetics plays a very strong influence in terms of what your body weight is going to be as an adult. And you can't change your genetics. I mean, I think that I mean, in some ways that makes it sound a little bit nihilistic, because, and I don't want it to come across that way, because I still think that there is, wherever you start, there's still that opportunity to think about making changes through lifestyle, through diet and exercise. But I think shaming people for not being able to lose weight is never productive.
No, and thank you for saying that. I working in mental health, I know what shaming and stigma and what that can feel like. So thank you very much for that. Richard, I've had so many questions for this interview. So what we're going to do is take a break on this video, and I'd like to thank Richard, but keep watching and waiting for the next one, because we will continue this discussion in the next video. So thank you, Richard, for now, and we'll keep recording for the next one.
Thank you very much, Shania, and lovely to join you.
And don't forget to subscribe so that you get a notification for the next part of this video. The views shared in this video are intended for informational purposes only and reflect current evidence and expert opinion. As every individual's health, metabolism, and circumstances are unique, please consult your doctor or a qualified healthcare professional before making any medical or lifestyle decision.